Hello everyone. This video has been given as a quiz withholding the history through Google form. You can also go through this video. Its answer will be given shortly. Of the participants, 4 have given the correct answer with their names given here. All the others have given their differential diagnosis. Congratulations to the winners and all the best to all the participants who have answered as the differential diagnosis. Thank you very much. The quiz might be difficult without any history. Now I am going to give you the clinical scenario and how she presented here. Initially, this 30-year-old asymptomatic lady came for viability scan with positive urine pregnancy test. I am giving the images taken at that time 2 weeks earlier to the video, so you can see and think about the findings. This could be much easier than the quiz video. She is a second gravida with the first baby delivered by LSCS 1.5 years back. There is a live embryo of 6 weeks 3 days by CRL at the level of Cesarean scar with thin anterior myometrium not indenting the posterior bladder wall. All the given images are highly characteristic of live embryo in exogenous type of ectopic Cesarean scar pregnancy with crossover sign 1. I will repeat the diagnosis. There is a live embryo in exogenous type of ectopic Cesarean scar pregnancy with crossover sign 1. She came after 2 weeks, and that's the video which shows ectopic Cesarean scar pregnancy with demised embryo. Now the embryo has demised and there is same thin anterior myometrium with preserved serosal layer. So the diagnosis is ectopic Cesarean scar pregnancy. Now we'll talk in detail about the Cesarean scar pregnancy, which sometimes be abbreviated as CSP. It's not easy initially, but if you know the pattern of CSP, you will never miss the diagnosis. Here we are going to discuss about CSP in full detail, and please share this with your good friends and colleagues. Let's go on. CSP is defined, means I am saying it's not the cavum septum pellucidum, it is the Cesarean scar pregnancy. Okay, CSP, that's the Cesarean scar pregnancy, is defined as implantation of a live or demised embryo at the scarred LSCS level in the anterior myometrium above the cervix. Incidence, you can see the I'm giving the common and less common types of ectopic gestation. Just go through that, see the image. All might be aware of all these types. I think everybody will be aware of it. We can also, I'm including an uncommon sites of ectopic pregnancy. Here it has been mentioned the intramural type of ectopic and the twin ectopic and the heterotopic twins, which have not been mentioned in the previous image. Please pause and reread about the incidence of all the topics. I think so all the ectopics which has been mentioned there. So I'm going to give you a quiz now. Okay, quiz is among women with an ectopic pregnancy having previous history of cesarean section, what is the approximate frequency of cesarean scar pregnancy? A 1%, B 2%, C 5%, D 6.5%. Please don't go back and reread about the incidence of all the types of ectopic gestation, right? The answer will be given later in this presentation. Now we'll go to the discussion of Cesarean scar pregnancy. Now we shall discuss about how this happens. This is because the blastocyst, which will progress to become as an embryo, is implanted between the endometrium and the LSCS scar due to the small communication which is called as isthmocele between the anterior endometrium and the LSCS scar. Now after this topic, when you see a fertile lady coming for routine scan and if you find LSCS scar with small linear communication or a cyst between the LSCS scar and the lower endometrium, which is called as isthmocele. This is particular if she has come for subfertility or for transvaginal follicular study. Please keep this in mind because they will have the highest risk of Cesarean scar pregnancy, right? Okay, we'll go to the next question. Are there any subtypes of Cesarean scar pregnancy, CSP? Yes, it has two or three subtypes. One is called exogenous type of CSP with the gestational sac implanted in the proper Caesarean scar. This is called as exogenous type. Now the endogenous type, two types are there actually, with the gestational sac implanted between the Caesarean scar and the endometrium. If it is near the endometrium, in between the endometrium, that's one type. The other one is towards the endometrium, near the endometrium, means close to the endometrium. That's the second type. So, but the exogenous type might become as the endogenous type later. With the same way, the endogenous type might become as a proper intrauterine pregnancy, lower side. So everybody should know that it depends at the time when the scanning is being done. For example, somebody would have reported as Caesarean scar pregnancy 2 weeks back, and today when you might see it as an intrauterine pregnancy in the lower or mid endometrium. So again, that's the pathophysiology of this Caesarean scar pregnancy. Please remember, the exogenous type has the risk of uterine rupture and hemorrhage, whereas the endogenous type has the risk of placenta previa and placenta accreta spectrum. Our quiz images are very typical of exogenous type of Caesarean scar pregnancy. You can see the endometrial line and you can see the Caesarean scar pregnancy. It's very typical of exogenous type of Caesarean. The endometrium is very separate from the scar pregnancy. Recently, they are also redefined with crossover sign, which is abbreviated as COS. COS. I am giving the appropriate picture with the long endometrial line between the uppermost end of the endometrium and the uterocervical junction below. Please see the picture. The line is not in the center of the endometrial line. Very important. It is not in the center of the endometrial line. It is the line between the uppermost endometrium, whereas the uterocervical junction is below, and it's a line joined between them. So that's then now you have to go for the line in the gestational sac, which is the line perpendicular to the endometrial line, which is called as supra-inferior line. It means away from the endometrium, and one is close to the endometrium. So that's why superior inferior. By these lines, they are subtyped as cos1, cos2 plus, cos2 minus. So what is this cos1? The cos1 is the exogenous type of CSP with more than 2/3 of S1, means supra-inferior line, away from the endometrium, which has the worst prognosis and having the risk of uterine rupture and hemorrhage. Whereas cos2 plus is the endogenous type of CSP that intersects the endometrium, which has worse prognosis with risk of placenta previa and placenta accreta spectrum. Now we'll go to the cos2 minus, which is the endogenous type of CSP that doesn't intersect the endometrium, which has less worse prognosis with less risk of all the above complications. Now we'll discuss about all the findings to be diagnosed as CSP sonographically. So one is we have to see normal endometrial canal. Second one is we have to see normal cervical canal. Then the third one is tiny or small gestational sac with residual ring. Fourth one is less than 5 mm thin endometrium anterior to the gestation. And fifth one is abundant blood flow in and around the G-sac and some flow between the posterior bladder wall and the G-sac, and that was also present in our quiz. So in all this, if all of them are there with a past history of Caesarean section, it is almost pathognomonic of Caesarean scar pregnancy. We'll go for the differential diagnosis. I think many of the participants have given the proper differential diagnosis. One is the abortion in progress is the most common DD with open cervical canal by products of conception, and there is normal anterior myometrium. But the difficulty starts when there is previous history of Caesarean. That's the problem. Here is the sliding sign, which will be very highly positive in abortion, but it will be negative in our in Caesarean scar pregnancy. So what is this sliding sign means? It will be sliding while we compress and move with the probe. It will be there almost 90%. Second differential diagnosis, cervical ectopic pregnancy, which is the next less common. It will have distended cervical canal showing a well-defined gestational sac with live or demised embryo, and here the sliding sign will be negative, right? Now the differential diagnosis, you can go through the table talking about the findings in the Caesarean scar pregnancy, abortion in progress, and cervical pregnancy. Everything has been properly given. So history of Caesarean surgery might be there in all of them, but definitely it will be 100% in your Caesarean scar pregnancy. Endometrial will be normal in all except abortion in progress. Cervical canal again normal in this cesarean scar pregnancy but not in others. Decidual reaction will be abnormal in the abortion in progress. Embryo and yolk sac cannot be seen on abortion in progress. Shape of sac again has been given, and sliding sign I think already discussed. So, but the difficulty happens when all of them come with lower abdominal pain or bleeding PV or sometimes spotting, and if all of them have the history of previous cesarean section, that's again very common one, which might also have isthmocele too. So it's a very difficult situation. Okay, with a long discussion about CSP, I'm saying cesarean scar pregnancy, we are in the final stage with a quiz answer being pending. So I'll repeat the quiz. Among women with an ectopic pregnancy having previous history of cesarean section, what is the approximate frequency of cesarean scar pregnancy is the question. So we have seen 1%, 2%, 3, 5% and 6.5%. The answer is D, 6.5%. And now I'll give the answer. Means in toto, the incidences actually would have gone through the given pictures, the images. The incidence of CSP in toto is 1% in comparison to all the other ectopics. But when we compare with when the history of previous cesarean section is there, then the incidence rises to 5%. And if the isthmocele is also present, or if she has conceived in vitro fertilization, it shoots up to 8 to 10%. I'm saying cesarean scar pregnancy becomes so common, 8 to 10%. So the given answer is almost 6.5%, even though 5% could also be correct. So I'm ending the session. That's all, dear colleagues, and I thank you very much for your patient listening, and it will be grateful to have more like buttons from you, and it's a great pleasure and happy to see your review and your thoughts in the comment section. Thank you very much. We'll meet you again. Bye bye. Take care.